Hi, today we will be learning a very important application of microengineering or microtechnology, and that will be force sensing. Now, it may come to your mind that why force sensing is so important, because you have been looking at or you may be looking at lot of force sensors available around you, right. But if I say that this force sensor plays a vital role when a heart surgery is performed or during a heart surgery. So, the first question that comes to our mind is how, right, and how come force sensing is used in a heart surgery. So, when we talk about heart, right, we see that whenever you work out, right, whenever you climb the stairs or run, your heart beats faster. So, faster beating of heart when you are performing a physical activity, it is normal. Faster beating of heart when you are static can be a corresponding or can be a signature to a particular disease. It can be arrhythmia. However, if the heart pumps unevenly, rapid, then slow, suddenly rapid, normal, again rapid, again normal, then that will cause a bigger problem, because it may cause a clot in the blood, and that clot can travel to other part of the body including brain and cause brain damage. So, that beating of heart, uneven beating of heart is called fibrillation, particularly atrial fibrillation. So, what exactly is atrial fibrillation? What are the techniques to cure atrial fibrillation, and how we can make the tool that is used in curing atrial fibrillation smarter. So, the tool that is used in curing the atrial fibrillation is called catheter. Is a tube that is inserted from the groin area and reaches the heart and ablates the tissue. So, when I talk about ablation, is nothing but burning, burns the tissue. Now, why suddenly burning comes into picture, why we have to burn the tissue, and that to our heart, we will talk about this things in detail once we go through the slides. So, if you see the slide, you can see that today we will be talking about smart catheters, or how can we make catheters smarter. So, we have all studied about heart. There is a superior vena cava, right atrium, left atrium, left ventricle, right ventricle, pulmonary valve, right, tricuspid valve, aortic valve. Same way we have pulmonary artery, we have pulmonary vein, correct. This is, and of course we have aorta. This is a general structure of heart that we all know. Now, the electrical signals that are generated from superior vena cava and travels through pulmonary veins, PVI. So, that can cause misfiring, that is uniform generally when the electrical signals are pumping into the heart. That have a uniform fashion, right, always, and due to that there is a rhythmic movement of heart, not uneven beating, but a uniform beating. But when this electrical signals does not form a particular pattern and misfires in random direction, this will cause uneven beating of heart. So, how we can treat this particular disease? Okay. Let us see how our heart looks like. So, you can see, right, actual heart pumping, and right. So, you can here clearly see what we are talking about. We are talking about aorta, which is here, right. You can see it right over here, aorta, right, pulmonary artery, pulmonary veins, superior vena cava, inferior vena cava, right, and this is how a heart actually looks like, guys. So, it is not something that is we used to represent, right, fancy version of the heart. Actual heart, when you see you will not really like it, right, and but having said that, this is nothing but a pumping organism, a pumping organ, and pumping organ which is extremely important for the for us to live, right. Now, let us first understand what exactly is atrial fibrillation and its role in causing the difficulty in the heart to pump, as well as possible curing mechanism. So, let us see this video.
Atrial fibrillation, or AFib, is a heart condition that causes the heart to race and beat in an irregular rhythm. People often say that when they have an episode of AFib, they feel as though a fish is flopping around in their chest, or that their heart feels like it will explode. AFib can increase your risk of heart failure, stroke, and even death. Because of these risks, and because AFib can get worse over time, it is important to have it diagnosed early and cared for appropriately. AFib is the most common type of irregular heartbeat, or arrhythmia. It affects over 2.5 million people in the United States alone. Your heart is a muscle that acts like a pump. With each beat, it squeezes or contracts to push blood to the rest of your body. Your heart has 4 chambers. The 2 upper chambers are called atria. The 2 lower chambers are called ventricles. Under normal conditions, the upper and lower chambers of the heart work together to pump blood throughout the body. The bloodstream enters the atrium, where blood is pumped to the ventricles in a regular and coordinated way. From there, blood is pumped from the ventricles to various parts of the body. A healthy heart beats in a regular, steady rhythm or pattern. Notice how the heart beats evenly and uniformly. In a healthy heart, electrical signals travel through the heart in a regular pattern, as seen here. These electrical impulses originate in a special section of the atrium and travel through the heart in a regular pattern. Each signal ultimately causes the heart to beat. In AFib, the top 2 chambers of the heart, or atria, beat very fast and in an irregular pattern that is out of rhythm. Notice how the atria appear to quiver and are uncoordinated. Due to this irregular pattern, the atria do not coordinate with the ventricles, and the heart is out of rhythm. AFib occurs when electrical signals start in the wrong place and misfire. The faulty signals cause the atria to quiver and not contract completely. Notice how the signals spread in a rapid, disorganized way. Your doctor may perform a test called an electrocardiogram, or an EKG, to see your heart's electrical activity and rhythm. During an EKG, small electrodes are placed on specific parts of your arms, chest, and legs using small stickers. When the heart beats, the electrodes send signals to the EKG machine. The EKG measures the electrical impulses or waves shown here as lines. See the differences between a healthy heart and a heart in AFib? In a normal heart, beats are evenly spaced and show a regular pattern. In AFib, the waves appear more chaotic and random. While the causes of AFib are often unknown, there are a number of things that increase the chances you might get it. Some of these include age, family history, smoking, high blood pressure, or hypertension and obesity. Also, if you have any of the following conditions, you're more at risk of AFib, heart failure, diabetes, or coronary artery disease. The more of these risk factors you have, the more likely it is you might experience AFib. Be sure to discuss your full medical history with your healthcare provider. AFib often gets worse as time goes on. It's important to take care of it early because the longer your heartbeat is out of rhythm, the harder it is to return to normal. In this chart, the red lines represent AFib episodes, and the blue lines represent times when the heart is in rhythm. When many patients are first diagnosed, they experience periods of AFib that may come and go. These episodes may be momentary or last for days, but generally go away on their own. This is called paroxysmal AFib. In some situations, AFib may not go away on its own. Your doctor may need to perform a procedure or provide medicine for a cardioversion to bring your heart back to normal rhythm. This is called persistent AFib. In some people who have had AFib for a long time, the heart may not be able to return to a normal rhythm at all. This is called permanent AFib. Notice that over time, the red areas are larger and more frequent. This is why it's important to talk to your healthcare provider to be sure that you're doing all you can to keep your heart in rhythm. There are many signs and symptoms of AFib. Many describe an uneven, flopping, or racing heartbeat. AFib can make you feel lightheaded, dizzy, or even short of breath. Some people feel tired or weak. Others experience chest pain or discomfort, such as palpitations. These symptoms might be subtle or severe, and they may come and go, and you may not experience any symptoms at all. In fact, 60% of patients don't even know when they're having an AFib episode. If you have AFib, it's important to know that while you may not feel symptoms all of the time, your heart may still be out of rhythm, and you're still at risk for other complications like remodeling or stroke. If left untreated, AFib can change the size and even the shape of your heart through a process called remodeling. Remodeling can cause permanent changes in your heart in a very short amount of time, potentially just a few days. Because of AFib, your heart has to work much harder, and heart tissue can be damaged. Notice how the heart increases in size and its walls thicken. Even if you're currently being treated for AFib, it's important to understand if your management program is addressing all the risks associated with the disease. During AFib, blood can collect or pool in your heart and cause a clot to form. If this happens, the clot can travel from the heart to the brain and cause a stroke. If you have AFib, you're 5 times more likely to have a stroke than someone who doesn't have it. It's important to talk to your healthcare provider about your risk of stroke and how to reduce it. You may feel exhausted and weak as a result of your heart not pumping properly. While some people with AFib may be able to lead a normal lifestyle, in some cases, having AFib can keep you from enjoying exercise and everyday activities. If you have AFib, you're 4 times more likely to end up in the hospital 3 or more times than those who don't have the disease. It's important that you continue to talk to your doctor about managing your AFib, even if you are not currently experiencing symptoms. The AFib treatment guidelines for healthcare providers recommend a comprehensive approach to treating all the risks of AFib. The guidelines prioritize 3 treatment goals: rate control, maintenance of normal rhythm, and stroke prevention. Healthcare providers may provide a range of treatments to jointly manage the different risks and symptoms of AFib. There are a number of ways that AFib is treated. Your doctor may prescribe a medication to slow down the pace or rate at which your heart beats. Notice that the rate medication slows down the heart rate. However, the heart continues to beat irregularly and out of rhythm. Rate control medications do not correct the irregular heart rhythm associated with AFib. They slow the heart rate down, but don't address the irregular rhythm or pattern of AFib. Your doctor may recommend a treatment designed to more specifically address the rhythm of your heart. When rhythm control medication is used, the heart beats in normal rhythm, but remains fast. Rhythm treatment regulates your heart rhythm, but may have little or no effect on the rate at which your heart beats. Combination of rate and rhythm control treatments may be recommended to reduce the heart rate and maintain the normal heart rhythm. Rate control medication is used to slow the heart rate down. When rhythm control is added, the goal is to have the heart beat at a normal rhythm. Other treatments for AFib may include surgical and non-surgical procedures and implanted devices. If medicine has not been effective, your doctor may perform a procedure called a cardioversion, in which electrical current is used to restore a normal heart rhythm. Radiofrequency ablation, sometimes called catheter ablation, is a procedure that stops the heart from setting off the faulty electrical signals that cause the chaotic heartbeats of AFib. Surgical ablation is a surgical procedure to destroy the cells causing abnormal heart rhythm. It may be used when other treatments have not worked. The surgeon treats the surface of the heart directly rather than relying on catheters and x-rays to reach the heart. For some patients, a small battery-powered device called an atrial pacemaker may be implanted under the skin to generate electrical signals to regulate heartbeat. Talk with your healthcare provider about which treatment options are best for you. Whichever plan you decide on, it's important to remember that AFib is a progressive disease. The longer you wait to restore your normal heartbeat, the more difficult it is for your heart to return to a normal rhythm. Finally, keep in mind that a comprehensive approach to treating all the risks of AFib is important.
Catheter ablation has emerged as an excellent, minimally invasive treatment option for atrial fibrillation. Our specialists are some of the most experienced in performing this procedure, with success rates among the best in the nation. They'll work with you to decide if an ablation is right for you. Doctors Patrick Chu, Brian Baranowski, and Waleed Saliba will tell you more.
For those patients where medications have not been able to control their atrial fibrillation, obviously their lives have been affected. Some patients can be very symptomatic with atrial fibrillation. It can interfere with their ability to do daily activities. So ablation as a means of controlling and settling down this atrial fibrillation can vastly improve those patients' lives.
We know the initial trigger, the initial spark or the initial firing for atrial fibrillation tends to come from the pulmonary veins. And these are the four veins that are draining blood that has just gone through the lung and picked up oxygen back to the left side of the heart so it can then be pumped everywhere it needs to go. There's little muscular sleeves that line those veins, and those muscle cells, for whatever reason, in select individuals can act in a very irritable fashion where they fire very, very rapidly. And that tends to serve as the initial spark that sets people off into atrial fibrillation, shorting out the entire chamber. Medicines, when we use them as an approach to the management of atrial fibrillation, try to calm down that irritability. When the medicines are ineffective, and we're going to take the patient to the next level of our therapeutic approach and go for an ablation procedure, what we're doing is burning or ablating the tissue around those veins to ultimately turn that tissue over into scar. Scar doesn't conduct electricity, therefore if there's electrical firing within the vein, that electrical firing can't exit the vein and short out the entire chamber.
So essentially, a catheter ablation is similar to a heart catheterization, which most patients are probably familiar with. Typically, at the clinic here, we use 3 or 4 catheters that have different functions. What we do is we put those catheters through the groin all the way in the heart. One catheter is, for example, an intracardiac ultrasound so that we can see what's going on inside the heart. Another catheter is the ablation catheter. And then we have a catheter which is the mapping catheter so that we can look at the electrical activity inside the left atrium. As we cross to the left side of the heart, the left atrium, this is where actually most of the action of atrial fibrillation happens, and we use the mapping catheter to see where the electrical activity is and how much electrical activity is around the pulmonary veins, and we use the ablation catheter to cauterize and eliminate this electrical activity and to confirm that we have isolation of the pulmonary veins so that the impulses that come from the pulmonary veins don't make it to the left atrium, and therefore maximizing the chances of keeping the patient in normal rhythm.
We don't use general anesthesia usually. We use something called cautious sedation. And they're comfortably sedated, usually sleeping, but readily arousable. The procedure itself, from starting from coming into the room and then to leaving the room, is probably around 5 to 6 hours. A lot of the time is spent in getting the catheters in, getting into the left upper chamber, and then at the end, getting everything out. So I would say about half the time is the ablation time.
A lot of the pioneering work in terms of driving how the ablation procedure evolved was done at our institution, so we had the experience with which types of procedures, which approaches, which catheters, which mapping systems work best. And I think that gives us an advantage then, having experience seeing the evolution of the ablation procedure take off in terms of providing the best possible approach that we need for our patients when they ultimately decide, and we decide with them, that the ablation procedure is the correct procedure for them.
So, you have seen this video, right, and you now know what exactly is atrial fibrillation. So, when you have atrial fibrillation, then the doctor inserts the catheter, and first is to understand the electrical mapping of heart. So, from the chamber you have to see where exactly the misfiring of signal happens, that you can see when you can understand and when you can map the electrical signals from the heart. Once you know what are the electrical signals or which is the area that is misfiring or electrical signals are abnormal, you have to treat those area. Treating those area, we have to ablate those areas, we have to burn those area. This ablation is performed by a tool called catheter. The electrical mapping is also performed by a tool called catheter, right, catheter for electrical mapping, catheter for ablation. So, now let us see this particular video. If you see the screen, you can see this video where we will be looking at the catheter ablation. So, now you know what is catheter ablation, right, and what we understand that for catheter to ablate, it can use RF frequency. So, it can be RF ablation, radio frequency ablation, catheter for radio frequency ablation for treating atrial fibrillation, correct. So, now atrial fibrillation, or in short it is also called AFib, is a significant health care problem caused by the uneven and rapid discharge of electrical signals from pulmonary veins, like we have discussed. The technique of radiofrequency ablation can block these abnormal electrical signals by ablating myocardial sleeves inside pulmonary veins. So, we can ablate, we can burn the myocardial sleeve inside the pulmonary veins. So, when you want to burn, you have to apply RF frequency. So, radio frequency will generate heat, this heat will cause burning of the tissue. Now, if this is the heart and if this is the catheter, we need to understand what is the force that we are applying or that a clinician is applying during the treatment. right. If the force is more, then the region which are not needed to be ablate also will get ablated, and if the force is less, then the recurrence rate would be higher. Correct. So, force sensing in catheter ablation is extremely important, first thing, right. Okay. So, catheter force or catheter contact force measurement during RF ablation can reduce the rate of AFib reoccurrence, right, because we know with the help of force sensing how much force a clinician is applying. So, an optimized force can be applied with the help of catheter contact force sensing. So, how it can reduce the rate of AFib recurrence? Since it helps to determine the effective contact of the catheter, effective contact of the catheter with the tissue, thereby resulting in effective power delivery of ablation, right. So, very important catheter contact force. Now, for that we will see a development of a 3D force sensor that we have worked in a laboratory to provide the real time measurement of a triaxial catheter force sensor, and the 3D force sensor consists of a plastic cube bead and 5 flexible force sensors. We will discuss about this in detail when we reach to that particular slide, and how these force sensors are fabricated. These force sensors are fabricated with the help of P.PSS, that is we have created or we have patterned or we have fabricated strain gauges using P.PSS, and there is a PDMS bump on the flexible PDMS substrate. We will see this how it works. PDMS is nothing but polydimethyl siloxane. We have calibrated the fabricated sensor and it is showing a linear response in force range required for RF ablation, and to evaluate its working performance, the fabricated sensor we have tested against gelatin. Gelatin is called phantom tissue, not real, phantom tissue. You can create a gelatin in the laboratory and you can test your fabricated force sensor. So, to press the force sensor against gelatin, we have used micro manipulator, right. We will see the use of micro manipulator, and also integrated on a catheter tip to test it with deionized water flow. So, we have tested the catheter in the water. Why in the water? Because actually when you insert the catheter in the heart, then the blood is continuously flowing, right. So, what is the effect of blood on the catheter contact force? That effect of blood we have to subtract from the actual force data that we are observing or measuring, right. So, when you talk about performing this kind of experiment, we have performed a catheter with contact force and we have measured in water to understand the effect. Okay. Both experiments simulated the ventricular environment and provided the validity applying the 3D contact force for force sensor in ablation, which is your RF ablation. Now, catheter ablation has become the standard and successful method for treatment of cardiac arrhythmias. It is already utilized or used in treating cardiac arrhythmias. Several technologies such as cryoablation, laser balloon, etc. exist for ablation, but the recurrence rates for atrial fibrillation, atrial tachycardia and ventricular arrhythmias are high due to inadequate lesion formation. The lesion is not formatted properly, then the burning of that particular region is not done correctly, then the recurrence would be higher. So, effective lesion formation is important to decrease recurrence and need for reablation. Several parameters are required for effective lesion formation. Some are listed here. One is power output, how much power we are applying, impedance, tissue temperature, catheter diameter, catheter stability and contact force. You see, so many things are required to get a perfect lesion formation. And one of the very important thing is your contact force, and thus force sensing becomes very important when you talk about the catheter, right, in atrial fibrillation and in general also. So, the ablation catheter diameter is also dependent on or is a determinant of lesion size. Catheter diameter depends on the lesion size. You see, standard RF low power catheter, the lesion size you see, and cooled RF high power catheter, you can see the lesion size, right. So, it depends on the catheter diameter. Now, you can see here cryoablation, this is a balloon catheter, right, laser balloon catheter. Here there are different types of catheters shown here. We have taken from clinicalgate.com and also a paper published in Nature Photonics. So, you can see there are multi-electrode catheter for ablation, there are laser balloon catheters for ablation, there are catheters for cryoablation. In this particular case, there is an endoscope, balloon, radio plaque, right, catheter shaft and lesion generator. So, multi-parameter catheters have been published and is used. However, still we require force sensor onto the catheter. Now, why it is required? Because to get effective lesion formation and to get idea what is the amount of force that we are applying, right, where we are applying during the surgery. So, you see here, right, this is the ablation scars, right, and this ablation scar depends on several parameters like we discussed earlier. It depends on how much power output is there, how much impedance is there, what is the temperature of the tissue, what is the catheter diameter, what is its stability and what is contact force. So many parameters are required to understand and to get effective lesion formation, right. Now, irrigation versus non-irrigation catheters. So, surface cooling reduces, you see here, surface cooling reduces risk of boiling and blood clot formation, right, because when you burn the tissue, there can be formation of boils and there can be blood clotting. So, if surface cooling is there, we can apply higher power and higher power is proportionate to a better lesion. So, higher power results in greater depths of volume heating, surface cooling prevents monitoring of lesion formation, right. So, standard RF low power versus cooled RF high power, we will go for cooled RF high power catheters. Now, you can see here excessive power, temperature and CF circuits, CF results in contact force results in complications such as thrombus formation, cardiac perforation or steam pop, you see. So, it is very important that excessive power is not okay, temperature excessive is not okay, optimum contact force results are important, otherwise there will be a formation of steam popping or cardiac perforation or thrombus formation, right. So, that is why if you see here there is a lesion size versus electrode radius, you can see the diameter here, right, and electrode radius here. Same way the depth versus electrode radius, depth versus electrode radius. Now, before ablation, as we have seen in the video, electrical mapping of the heart is performed using an electrical sensitive catheter to understand the problematic areas of the heart that creates electrical signal, right. So, like you see there is a small incision that is created here and the catheter is inserted, as you can see it is moving towards here, right, and then it goes here inside and it reaches here, which is right over here. Then the electrical mapping is carried out to understand which area is causing the misfire of the signal. It can be in the it can also be in the ventricle, right, can be in auricle, it can be in ventricle. So, it is not just limited to auricle, it can be ventricle, but the PVI, right, cerebral PVI is measured to understand the areas producing abnormal signals. Once we know the abnormal signals, then we can treat it by ablating that particular area of the heart or area particular tissue. So, once electrical mapping is done, then another catheter is inserted to destroy the malfunctioning tissue using a catheter to deliver energy such as radio frequency or chirotherapy to scar the problematic areas. So, one is of course, you can heat it and destroy the tissue. Heating RF frequency will cause burning of the tissue. This burning of the tissue will cause the ablation and the electrical signal cannot pass through this ablated tissue. Second way of doing is chirotherapy, which you can see here, is by freezing the tissue. So, when you use a very cold temperature, then the tissue will start burning again and that will also cause stopping of electrical signal or passing of electrical signal to the tissue, because the tissue is burnt. So, the ablation of the tissue can be done with the help of the catheter. So, first catheter for electrical mapping, second catheter for ablating the tissue, correct. Now, if that is the case, are there any existing catheter that can measure the force, right? There should be some existing catheters. So, there are two companies, there can be many, what I am showing today is two companies, the catheter which are used currently in treating atrial fibrillation. First catheter is a catheter force sensing technologies that was developed by Catheter, where there is a force sensor, there is a saline irrigation holes, there is a tip electrode which about 3.5 millimeter, there are ring electrodes and there are optical fibers. So, if a body deforms, then correspondingly the optical using optical fibers the force is measured, right. You can see here normal force, axial force, lateral force, you can see here, right. So, force sensing with the help of optical measurements and using optical fibers has been done, and it was published in 2008 and right now it is used in surgery, right, in operating patients that are undergoing through RF ablation procedure. Another catheter is from novel thermocool smart touch catheter, a remote controlled robotic catheter ablation with usual and vibration force feedback, that is a IntelliSense, but we are talking about novel thermocool smart touch. So, most recently this particular catheter is available in the market, which can provide the real time contact force feedback in combination with 3D electroanatomic mapping system. So, it can not only perform the ablation, but it can also map electrical signals 2 in 1. There are of course irrigation pods for saline to come out, right, for saline. There are tip electrodes for applying the RF frequency. There are sensors inside the catheter. There is a catheter shaft, right. There are electrodes over here also, magnetic transmitter coil is there, right, precision spring is there, and it can not only measure the force sensing, it can also do electrical mapping and also apply RF ablation. Again the catheter contact force ablation catheter is about 3.5 millimeter in diameter. Right. So, this is what we have talked about the existing catheters and about atrial fibrillation. Atrial fibrillation. So, what are the gaps? Very important. What are the gaps in the current technology and how can we fill those gaps? So, one of the thing is there are no existing catheter with both electrical mapping and RF ablation catheter in one. However, we have just seen that recently electrical mapping and RF ablation can be done using single catheter. So, now this is not anymore a gap. So, then second thing is stim pops cannot be accurately predicted, this is a gap. Irrigation hole obstruction by the tissue, another gap. Unequal cooling of catheter tip and tissue, another gap. So, how can we reduce these gaps or how can we fill these gaps to make the catheter smarter? Right. First is our catheter should be working as not only for as a electrical mapping catheter and also as a ablation catheter, that is the first choice. So, that means that if I have a catheter that can perform radio frequency ablation and electrical mapping both together, then it is a uniqueness. So, what kind of design I can do so that I have both in one, right. So, if I have this catheter and if the tome shape opens up, and another catheter comes out which can perform the electrical mapping, then it can do both electrical and this external, this one can apply RF frequency. So, it can perform RF ablation. So, understand that this tome opens up, right, it opens up. So, you can see something like this and the catheter within it will come out and perform electrical mapping, right. Catheter within this tome shape structure will come out and perform electrical mapping. When we do not require this electrical mapping or we are done with electrical mapping, we can close this tome shape structure again and the catheter will move down, right. That is our interest. Of course, the schematic is not so cool what I have drawn, but that is what we want to show. So, point is this is what we are addressing. Can we design a catheter that can perform RF ablation as well as electrical mapping both in one, and what kind of force sensor we can insert on this particular catheter. So, in the next module we will be looking at what kind of force sensor we can design, what kind of force sensor we can implement on the catheter and how this force sensor can be used to get a contact force measurement. Also, what kind of force sensor we will be using, and we will talk about few results that can that we have obtained, and you will be learning this as a part of this course, that how to design or how to design a force sensor, right, because force sensor we have designed using micro technology. and in as an application you can see now that a force sensor, or you will be able to see that the force sensor can be integrated onto a catheter to measure the catheter contact force during the ablation. So, just go through the video once again, learn these things in detail, and once you understand what is arrhythmia, what is atrial fibrillation, what are irrigation catheters, what are the how the electrical mapping is done, how the contact force is taken, then you will be able to understand what kind of gaps are there in a particular technology and how can I fill the gap by using my existing knowledge of microtechnology. So, I will see you in the next class to tell you more about what kind of force sensor you can think of and how you can integrate that force sensor onto this particular catheter. Till then, you take care. I will see you in the next class.